Welcome, anal cancer thrivers, caregivers, and providers. Thank you for being here. We're so happy that you are joining us on this Anal Cancer Awareness Day for our program, Taking Care of You, Tips and Exercises to Restore Your Pelvic Health After Anal Cancer Chemoradiation. My name is Justine Almada, and I am the co-founder and executive director of the Anal Cancer Foundation. My brother Tristan and sister Camille and I founded this organization after serving as caregivers for our incredible and beautiful mom, Paulette. Our mom was diagnosed with stage 4 anal cancer some 10 years ago, and there were scant resources at the time to help her fight the disease. In the last 10 years, we've raised awareness, we've funded groundbreaking research, we've advocated for prevention, and we've empowered patients with information and community. I am particularly proud of our support for the first ever immunotherapy for anal cancer, the first ever Anal Cancer Medical Society, and the first ever peer support program just for anal cancer thrivers and caregivers, where we will match you with someone at any point in your journey. I know you've been through a lot, and we want to help you thrive, whether you're 2 weeks or 10 years out. We've learned that the side effects of chemoradiation can stick around. As we've seen from hundreds of patients over the years, there's treatment, post-treatment, and then there's post-treatment. That's why we recommend that people who have experienced anal cancer chemoradiation seek 3 experts in the field of oncology to help mitigate the side effects: a pelvic physical therapist, like our speaker today, a nutritionist or dietitian, and a sexual health therapist. Please consider asking your oncologist for a referral. Today's program is focused on pelvic physical therapy. We wanted to give a practical overview of what happened to your body during chemoradiation and simple exercises you can do at home to start addressing it. We will end with a live Q&A. For today's event, we received over 100 questions, and Dr. Romero has added time and information to address the most common concerns raised. Due to the nature of Wi-Fi, there may be moments when the screen glitches. If that happens, please just bear with us, and it usually fixes itself after a second or two. I want to extend a special thanks to our friends at the Farrah Fawcett Foundation for being our co-sponsor of this event. I'm excited to introduce you to Dr. Allison Romero. Allison has a doctorate in physical therapy and first became part of our Anal Cancer Foundation family in 2014 as a speaker at one of our first anal cancer forums. She has served as a resource to the community ever since, writing our series on pelvic floor physical therapy, serving as an expert, and providing one-on-one care to thrivers. It is my absolute pleasure to welcome Allison to today's webinar. Allison?
Hi, thank you, Justine, and thank you everyone for being here and coming. Okay, Justine just introduced me, but let me introduce myself again. My name's Allison Romero. I have a doctorate in physical therapy, and I began specializing in pelvic floor physical therapy 10 years ago. And just like Justine said, around 2014, I had been seeing a lot of patients. I was working in San Francisco, and I'd been seeing a lot of clients coming through post-anal cancer treatment. And I ended up getting in with Justine and your guys' group, and I've just really enjoyed working with this area ever since. So in that time, I've had 2 kids. I ended up opening up my own small practice so that I could have more flexibility with them. And a large percentage of the people that I see are post-cancer treatment in some way, and anal cancer is certainly like a big portion of that. And it's what I think is so, like, this foundation is changing like your world and our world in some ways, because it's become mainstream now to rehab after like a mastectomy or after breast cancer. And what I'm trying to get the word out is, if we could rehab after all cancer, especially something in the pelvis like anal cancer, where there's been so much stress to these tissues in such a small area, we could just see better outcomes overall and better quality of life. So that's like my main message to get out to the physicians and people that are in referring powers. So let's just talk. I think a lot of you guys already know, but we'll just talk kind of about what can happen after treatment. And like Justine said, we got all of your questions, and thank you so much for sending them in ahead of time. We went through them all and divided them into 5 categories. So these are the categories. So you guys can be thinking, I'm going to address them in about like 10 minutes or so. I'm going to address all of them. And then if there's more questions, you can submit them at any time, but we'll look at them for the Q&A at the very end. So we're going to talk about control of the anal sphincter, fecal incontinence, urgency leakage, vaginal anal stenosis, pain, pelvic leg pain, and scar tissue. So we're going to specifically address those in their own category, but I'm going to go through some stuff now. And if any questions come up, obviously put them in the Q&A section and we'll try to get to them at the end. So let me just first go over the anatomy. So I've got a pelvis here, and this is a female pelvis. I printed out some male pelvis anatomy. It's very, very similar to the female pelvis, and I'll just kind of address that here. So if you can see, this is the pubic bone, and we're going to talk about some of these anatomical points down the road. So we'll come back to visualize this, but we've got the pubic bone in the front. So that's just down below the belly button. It's like a hard bony prominence below your belly button. We've got our spine, you can see. And if I turn the pelvis around, so this is the back. I don't know if you guys can see, we've got the tailbone here. And this is the anal coccygeal ligament, and it just goes right into the anal sphincter. Okay, so I'm going to flip it around again. So now the pelvis is lying down facing you. So we've got the urethra, the vaginal canal, and the anal sphincter here. And you can see this is a pretty to scale model. It's like a few inches between all of these structures. So no wonder that we can, post-treatment, we can be having urethral issues, vaginal issues, anal sphincter issues as well. And then pain in the general area as well, and stiffness. So in females, we've got the urethra, which comes with its own sphincter. This layer of muscles is called the urogenital diaphragm, and it's all sphincteric muscle. And it's all responsible for keeping things closed or letting them open in the appropriate time. The vagina has a sphincter here, and the anus has a sphincter. So in men, this area would be closed. That's fused. There's obviously no vagina there. And I'm going to just attempt to show you guys. Can you guys? That's the male pelvic floor. So there's a penis there. The urethra is coming through the penis. This area is fused. That's the perineum. So they have a longer perineum, and then anal sphincter. Okay. And men obviously have a prostate. So that's the different thing for men. That's going around the urethra, and that can be affected in this treatment too. So that's the difference there. So we've got this outer layer of muscles called the urogenital diaphragm that is responsible for letting things out and keeping things in. And then I'm going to show you guys inside. We've got a whole nother layer of muscles, and it's like a bowl. And that is responsible for holding all of the organs up. So they're all doing really important stuff. And then I wanted to show you the organs. So can you guys see that? We've got the bladder here. This is a female model, so we're going to have a vaginal canal in between and a rectum, okay? And the anus is the lower 1/3 of the rectum. So they're all kind of important in keeping each other together and keeping each other safe. In men, we're going to have the rectum and the bladder closer together, and the prostate is going to be right here below the bladder, okay, around the urethra. So I'm going to take everything away except for the rectum and the anus. So here it is. And what I always tell people is, like, nothing is isolated. The anus is not really different than the large intestine. It's all a part of the large intestine. And so let me just see here what's going on. Okay, so the large intestine is one, and the anus is the very last third of the rectum. Okay, so it's like probably the last, very little percentage of the full large intestine, but the very lower third of the rectum. And the reason that it's a different tissue than the rest is because it's doing a sensing, activity basically. So it has sensors in there deciding, is this liquid, solid, or gas? And solid, typically we would be like, okay, it's solid, I can wait to get to the bathroom. This is all in a typical functioning anus, and I'm going to go when I need to. Gas is a little bit harder. I'm sure we've all had instances where we're like, oh, and then liquid is like, we're not meant to keep liquid in. Liquid to our brain is like, oh, something needs to get out fast, so we want to get that out. So liquid is always harder to keep in than solids or gas. And so that's what the anus's job is. It has two sphincters. That is an internal sphincter, which does 80% of our continence, and it has an external sphincter that is responsible for the additional 20%. And the external sphincter we have control over. The internal sphincter we don't have control over. So that's controlled by our autonomic nervous system that just runs itself. So this is all something that I would love everyone to know going into this treatment, just so you know what the anatomy is going into it. So that's the main stuff I want to talk about, just our typical anatomy. Now, when we're going through treatment of cancer, we're getting chemoradiation, and even just, even if it's just one chemotherapy treatment, that is a pretty serious amount of medication coming through, and it's poisonous so that it's killing, anything that is, multiplying too fast. And then obviously there's radiation, and that's burning the tissue, and that's making it so that tissue cannot continue to proliferate down the road. So that's great, but it's also, scarring up tissue, making it difficult for it to move the blood and kind of keep its flow. And then there's sometimes surgery involved, right? There's sometimes surgery, and that is just an incision, and that's always an injury. Surgery is always an injury. So you can imagine, with all of these insults and injuries to this tissue, how important it would be to address how that tissue is able to move, how it is able to activate, how we're able to address that. So I'm so happy that we're getting to talk about it, because there's so much that can be done. Whether we're starting right away, or like Justine said, whether it's been 10 years, there's still improvement that can be made always. So that's what I'm excited to talk about. Okay, I think I'm covering most of our things. Yes. So when I usually get someone in my office, they're through their treatment, and where it's like, yes, made it through that step. But it's also a little bit scary, and I'm sure you guys, can relate to this. It's like, okay, well, I kind of feel like I'm in a new normal. Is this the new normal forever? Can I get back to my old normal? And it's like, yeah, let's work towards that. That's what we're always going to work towards. Like, how much normal can we get there? And so usually when I have someone come into the office, I'm seeing, and I'm looking at their pelvis, and I'm looking at their fascia and muscles, I'm seeing a combination of tightness and kind of, I say, like, offlineness. It's not with us. Because in insult, and you guys can, I kind of compare this to if you got punched in the arm, right? You would hold your arm close to you, you would guard. And if that continued to happen, you would almost leave. You would just leave that arm, because you need to do, the rest of your body needs to function. And so you would just say, okay, that arm is getting hurt, but it's not, I have to move on. So that happens with other treatments as well. So with anal cancer treatment, when you're going through the chemoradiation and potentially, surgery, that other kind of, that's sometimes a third thing that happens. The body often will tighten to guard against these things, and then it will leave at some point. And so when I say leave, the brain just sort of takes some of its nerve input away so that it can deal with the rest of life. And so we want to bring that back. We want to remap the area to the brain and bring awareness again and bring healing. Because if the brain can see it, then it can bring life and it can heal it again. So let's see, I just have to always check in with my notes occasionally so I don't get ahead of myself. So in my ideal world, if I could have people coming in, right away after treatment, and this would be like the ideal standard. If the last thing that your oncologist did was refer you to, like Justine said, to a pelvic physical therapist, a nutritionist, and a sexual healer, doctor, sexologist. That would be ideal, because these are the issues now that we're going to need to move forward through. So, but like I said, sometimes people come in 10 years post-treatment and maybe they hadn't even had any symptoms until just now, or maybe they've been having symptoms and we need to treat them. It doesn't really matter. We're just going to start with where we start and assess what that's at. And there's just, there's always more room for improvement. So, that's my main stuff that I wanted to kind of introduce. The questions that you guys sent in are, I think, blanket. Most people are going to have these questions. So I'm just going to kind of go into the categories and address them. And then if there's more detailed questions, feel free to send them into the Q&A section. But the first one I'm going to go over is anal sphincter control. And so the reason that this is sometimes hard to have post-treatment is because that is a voluntary muscle, and at the very least it has had radiation, so it's been burned. So you can imagine, if any other, if we just think of it sometimes as like, it's easier sometimes to think of it as something that we can see, like a limb or something. If my elbow had been burned, I might be holding it in a way that's like, oh, I can't bend it, I can't straighten it, I'm holding it. So the first thing that we need to do is bring length to that, and then re-strengthen. And so what we're going to go over in some of the movements today, it's not rocket science. You don't even necessarily, if there's not a pelvic PT in your area, don't fret. It's not like, I would love it if everyone could get in with a pelvic PT for an evaluation, but this is something that we can just address by breathing. So in our breath, we're able to lengthen the pelvic floor, because to allow the air to come in our lungs, our diaphragm has to descend, and so does the pelvic floor. And so the anal sphincter actually has to lengthen to allow a full breath to come in. A lot of the time, we are breathing more in the chest and neck, and that is not even allowing that range of motion to come through our pelvic floor. So if we just were to spend some time doing breathing and address our breathing throughout the day, that would bring so much length to the anal sphincter that would then maybe give it the ability to now shorten, right? And then work a little bit better. So when it shortens, it's closing the hole. So that would allow it to maybe address, what's going on with the control there. And this is, like I said, the external anal sphincter is 20% of our sphincter control. The internal anal sphincter is 80% of that control. So, we want them both to be working. If the internal sphincter is having an issue, what we can sometimes do, breathing actually helps that too, because it starts to decrease our autonomic sympathetic nervous system, which is like our fight or flight. So when we're in fight or flight, I don't know if you guys have ever seen this in like a movie, or if it's ever happened, where like if you got really scared, you could like pee or poop your pants. Well, that's because sometimes in fight or flight, our body's like, let me clear out everything so that I can now run away for, as long as I need to. So in this world, we don't usually live in like, in that where we're needing to run away from like an enemy or a predator, but we can be in these little like micro fight or flights all day. For me, it's just like traffic. If there's traffic, I'm like, oh, I start getting tense. I start breathing into my chest, or, if one of my kids is like fighting with the other, I go into like tight chest breathing. So this is something that is so helpful, and it seems so basic, but because the internal anal sphincter is controlled by the autonomic nervous system, which is our fight or flight and our rest, digest, relax, tapping into that can actually give it some health. So see, it's very simple, but super effective. And we're going to go over some breathing today. So I'm just telling you now that breathing is going to be a big part of all of our lives as we move forward through this. So the next category that I wanted to go over was fecal incontinence and leakage and urgency. And they're all kind of different, but they all kind of go together. So The reason why this can happen is damage to either of the sphincters, sensor damage to the anus, and usually in anal cancer, that's one of the big things, is that the sensor has been injured because we've had to do so much to the anus tissue. So it's having a hard time knowing, is it solid, is it liquid, is it gas, like what's in here? I think I should just let it out. We have to give it a lot of kind of credit for how much it does, and it's hard for it after all this stuff has been going on. So if the urgency is happening where you're like, oh my gosh, I don't know if I can get to the bathroom on time, that's always a sensor issue. And sometimes what happens, because the sensor's feeling insecure, the sphincters will start like over contracting, and that'll tell our brain like, oh, it's an emergency. And so one thing that you can do in that situation is breathing in that moment. So deep breath, having a mantra, I am safe, I've got this, and kind of like purposely walking to the bathroom from there. So when we're in an urgency situation, we want to make sure that we've got like a trust going on between our bowel and our brain and our bladder, if we're talking about urinary urgency also. So we want to make sure that we're like going when that urge comes. And I know it's really hard to get anything done when you're having to, be like this. But if we can get a good even 3 days under our belts, then we can continue to improve from there. And another thing is, and this would be like a nutritionist, this would be the best thing that a nutritionist could do, is getting our bowel quality as good as possible. And so sometimes that means working with how much liquid you're drinking, what you're taking in, different irritants. Everybody has different irritants, but in general, if you're having any of this, incontinence, urgency, leakage, I recommend looking at your caffeine. And I know it's so hard to eliminate, but it's an irritant in a major way. So if we could eliminate or decrease the caffeine or just change the routine, that can sometimes go a long way. Refined sugar, carbonation, and alcohol. Those are all like major irritants to our system. And, at least while we're healing, and like I said, this can be at any time, but at least while we're healing, to make improvements, we want to really decrease or eliminate that stuff out of the diet so that our large intestine can feel as safe as possible. The last thing I was going to say about urgency is, in the moment when you have that urge and you're like, oh my gosh, I have to go to the bathroom so bad. If you can, like I said, take a deep breath and do 5 quick Kegels. So you're doing like 1, 2, 3, 4, 5. Doesn't even have to be like a full Kegel, just squeezing as much as you can, as fast as you can. The brain sometimes takes that as an interruption to this whole loop. And it's like, oh, you're in control. You understand what's going on. Okay, then I can let go. And so sometimes that can help with that urgency process. We call them quick flicks. So you just kind of interrupt that process, and that sometimes can allow us to have a little bit more time to get to the bathroom, and in the end, eventually get out of the urgency cycle, because it's a cycle that we get into. Leakage, as I was discussing, sometimes that anal sphincter is injured or the sensor's having issues. So usually leakage is liquid coming through that isn't like getting joined up with the rest of the stool. And so often in this situation, we need to look at how can we bulk our stool better. Psyllium is one way, chia seeds, anything that soaks up water in your diet is going to be helpful for that. So oatmeal, quinoa, rice, that kind of stuff tends to bulk the stool a little bit more. And this would be something that would be great to work with a nutritionist too. But psyllium husks, Metamucil, those are going to kind of like suck up the water that's in the large intestine and help that stool become one. So the better we can move one whole stool through the large intestine, the better we can, avoid that leakage. And there's so much more that I could say on all of these topics, but I just wanted to touch on them all. Incontinence. So I consider this is all technically in the incontinence realm, but I'm dividing it into, these different categories. Incontinence, I'm going to consider losing full stool or like losing partial stool in a more significant way than just a little bit of leakage coming through. This can be due to the internal sphincter and the external sphincter having some loss of elasticity. And like I said, giving it some length, sometimes using a dilator in the anus can help to give a little bit more elasticity and give it a little bit more range to have more control. Diet's going to be big for this too. Movement is big. So moving your body is going to be helpful in this situation. And having your best full complete bowel movements is going to be, all of that's going to be something we want to look at. Last thing is, if we can get into a routine for bowel movements, it's not everyone gets into this, but if we can sort of like, the last time we eat is the same every day. So maybe it's like 8 o'clock, no more eating. Sometimes the bowels will get on a routine by like the morning. They'll kind of know, okay, 20 minutes after you wake up or so, after you have that first glass of water, it's time to go. And that sometimes can help our body just understand what the day is going to look like in regards to this. Because if it feels out of control, it just kind of starts acting out. So stenosis, right, can happen to any canal. And typically in this situation, it's going to happen in the vaginal canal or the anal canal. And that is because radiation is burning tissue and it's causing scar tissue and kind of replacing some of the mucosal membranes, or not replacing the mucosal membranes, but just sort of like bulking up the mucosal membranes, because scar tissue is different than the collagen that was there before. It's still all collagen, but it's a different type of collagen. And radiation, they sometimes call the gift that keeps on giving, because the scar tissue takes it so seriously, it just keeps building and building itself. And so in that first year of treatment, and I know a lot of you are past this first year, but ideally in that first year of treatment, if I can get people to address the tissue on a daily basis, that doesn't always mean a dilator every day. And I understand how hard it is to use a dilator and the trauma that comes with just like inserting a dilator when you've just had so much going on there. So that's why it doesn't always mean a dilator every day. It might mean a finger on a daily basis. And, like when you're getting in the shower, maybe it's a finger and you're just inserting it into the anus or the vagina or both, just touching the tissue to give it some space, just a little bit. It doesn't need to be aggressive. Now, if we're past, let's say we're 10 years or 5 years past our end treatment date, it's not too late. So there's always elasticity in this scar tissue, and scar tissue is very brittle. And so it breaks, which is a good thing. And that is why scar tissue overproliferates so much, because it knows it's brittle. It knows it's not as elastic as the original collagen that was there. And so it's so fun to work with scar tissue for me, because there's always improvements to be made. And with the dilator, it's just, I do recommend having some dilators in your arsenal, and working up to that. You can start with the very, very smallest. You can start with your pinky and just insert and touch the tissue. And I usually recommend, if you can see, if this is the canal, whether it's the vagina or anus, starting at like 1 o'clock, thinking of it as a clock, and just pressing along each hour of that clock, so you just go 1 o'clock, 2 o'clock, and I'm literally just putting a small amount of pressure on each hour of that clock. And that goes a long way. And it also tells your brain that it's safe to touch that tissue. So sometimes before jumping into dilators, I just have people do that. And dilators are not the end all be all. They're helpful for getting the most space. So if that's what we're needing, if we need the most space, we'll start to work up and through the dilators, but we can always just start with a finger touching that tissue. And I wanted to touch on erectile dysfunction. This is something that can happen because, again, those erectile tissues are right in the zone of where that radiation is coming through, and so they can get injured. There is some evidence that suggests that strengthening the pelvic floor muscles can help with erectile dysfunction, and that's because it's, again, like bringing length and strength to the tissue and moving the blood through. And that's really what erections are about, is moving the blood through. So if the flow is getting stopped, it's going to be harder to, maintain or even achieve an erection. If we can get the blood moving through, it's going to be better. There's also some evidence that using a penis pump at any time is helpful to, like, having a program of using a penis pump like a couple times a week can help to maintain that flow. So that's usually what I recommend when we're talking about erectile dysfunction in this situation. And we can go into that again later if we need to. Pain, I don't know if people are expecting any of this stuff after treatment, but I think pain is often really surprising in the pelvic and leg area. It's just like, what? This was not about my pelvis and leg. Why am I having so much pain and stiffness there? And again, because the tissue is all contracting to guard against the treatment, they're all connected, and the hips are right there, and they're like, oh my gosh, we have to get tight too. And so I always encourage movement, and the best movement is going to be, when we're going to do this today, is going to be hip flexion, or knees coming towards your chest. So that can look like working into just bringing a knee towards your chest. That can look like some yoga poses. I'm a big fan of, gentle yoga in these post-treatment days, because it can just help to very slowly start moving you towards these ranges of motion. It can look like child's pose. It can look like more of a squat. That would be like the more of the final expression of what we're trying to go for. But this is something that you can do right away. This is something you can be doing during treatment. This is something you can be doing 15 years post. It is always ready to improve and continue to move. And so some of what we're going to do today, I'm going to take you through a flow of really simple hip and leg range of motion exercises that you could just do on a daily basis, and you would see improvements. That pain is because the muscles are so tight and that fascia is so restricted. And if we could get them moving more, they would be able to pump out the chemical inflammation that's just kind of hanging out around there. So that's often why there's pain and stiffness post-treatment. Scar tissue, I've kind of touched on this a lot, but I'm going to just give it its own moment. Because the radiation causes so much scar tissue, and if you've had surgery, obviously we're dealing with scar tissue in that way too. The brain is hoping to send the scar tissue to patch up any weak areas, or any areas that are getting constantly, radiated, to defend itself. And like I said, it tends to overdo in this situation. And the best way that we can address it is to give it constant feedback that it's safe and it's okay. So just touching the area once a day can start to decrease the amount that the scar tissue feels like it needs to come in there. So that can be external or internal. And this is something that just throughout the lifetime, I would have someone check in with, in the beginning when we're first making all the progress. So that's just the beginning of treatment. PT treatment. I want someone addressing this every day. And then once you get to a place where, we're in the maintenance phase, it's just touching base as needed. And you'll kind of know when you need that. And it's something, like I said, that you would do just throughout your lifetime, touching base with that scar tissue. So those were like the main categories that the questions came in through that I wanted to cover. And, obviously if you can, and I'm going to give you the resources of how to find a pelvic PT in your area, but if you could work with a pelvic PT, even just for one session to kind of get a plan, I always recommend that. The stuff that I'm going to take you through next is something that is safe to do and that anyone can do at any time to just make some general improvements. But yes, if you can get in with a PT, and I know a lot of PTs, including myself, with the pandemic, have started doing some virtual visits in some capacity. That might be something that you're able to just, find somebody in the online realm, and you're able to have a conversation with them about your specific situation and develop a plan from there. So it doesn't always have to be in person. There's a lot that can be done just through conversation. So I would encourage you to talk to your oncologist, look in your area, see if there's someone that you can connect with. So without further ado, I'm going to take us into the movement section. So if you have a yoga mat or something that you can lie on, a couple pillows, gather that up. I'm going to go onto my yoga mat, and I'm going to take you through about 15 minutes of breath work, movement, and some pelvic floor activation stuff. So let's all get ourselves situated. I'm going to lower my camera here so that you all can see my yoga mat. Okay. Okay, so I'm going to come into a lying down position. I want you to come into whatever position feels most supported and comfortable for you. For me, that looks like a hook lying position. So my knees are bent. Just seeing if you guys can see me here. My knees are bent. My body is flat on the ground. For some people, a pillow under the head is going to be really comfortable. For some people, a pillow under the knees is going to feel really supported. Some people, putting a pillow on their abdomen is going to feel good to them. Okay, so whatever feels most supported to you is where I want you to be, because we're going to go into the breath work first. And this is a place where we want to feel just like we're not doing any work. We're completely supported by our environment. So once we all get into this position, I'll give that one more second to get there. We're going to just start to take some deep breaths in through the nose and out through the mouth. And that's going to start to engage our diaphragm. And like I was saying earlier, the rib cage surrounds our sympathetic and parasympathetic nervous system. So our fight or flight and our rest and digest. And when we breathe just in the chest, it tells our body that we're in fight or flight. When we breathe into the abdomen, it tells our body that we're safe. We can actually take the time to take a full breath, and we can rest, digest, and start to flow down in through our pelvis. So what I want everybody to do is put one hand on the abdomen, one hand on the chest, and deep breath in through the nose. And you're going to feel the rib cage expand forward to both sides, into the back even. We're going to expand it in 4 planes here. So front to back, side to side, up and down. That's actually 3 planes. So that's what we're looking for. We're breathing in through the nose. Breathing in through the nose, again, tells our body that things are safe. And gently out through the mouth till we complete our full exhale. Now, I don't necessarily want the abdomen to be moving more than the chest. I don't want the chest to be moving more than the abdomen. We're looking for balance. We're looking to open the airways, increase the flow, and change the pressure system that's within our trunk. So when we can get the diaphragm moving, we can get the pelvic floor moving. So let's take a couple more inhales here. On the next one, I want you to visualize the pelvic floor, and in particular that anal sphincter that I showed you. I want you to envision that lengthening out towards your feet and opening just a little bit on the inhale, okay? So let's inhale. And then exhale, everything recoils and comes back to its resting length. Let's do that 2 more times. And let's do 1 more inhale, one last one. And exhale. So hopefully just from those few, minutes, just 2 minutes of breathing, you're, just feeling a little bit more calm. Maybe the head feels a little bit clearer. Maybe you feel a little bit lighter. And that's what breathing can do. For you all at home, I would like you to do this 5 minutes a day. And that's what I usually, give people as a home program. 5 minutes a day of breathing feels like a lot. And it is. And you can do it all at once before bed, or you can do it spread out. You can do a minute here, a minute there, 2 minutes in the morning, 2 minutes at night, that kind of a thing. But I want 5 minutes of focused, thoughtful breathing per day. And that is going to help your nervous system.
So the internal sphincter that responds with the nervous system, and it's going to help our external musculature, the external sphincter, the rest of the pelvic floor, to give it some length so that it's resting at its normal resting length and not tighter than it needs to be, which is inhibiting its function. So that's really my important spiel on breathing. So we're gonna stay, if you're, whatever position you're in, we're gonna stay in it. So for me, I'm in this hook lying position. If you're on your side, we can stay in an on the side position. If you're sitting, that's fine too. But what we're gonna first do is bring our knees to our chest. So in sitting, this might be a little bit difficult, but you can think about just, if you're in a chair, you can bring one or both legs up on the chair, or if you're sitting on the floor, you can just bring one or both legs into more of into your chest position. We're lying down, we're gonna bring both knees into the chest. And we're gonna just take a few breaths here. I'm gonna have my hands on top of my knees, or I can also put them under my knees. And I'm just gonna bring them into my chest a little bit. If you start to feel a pinching in the front here, don't go as far, okay? Just rest the hands on top of the knees if we're feeling a pinch into the front of the hip joint here. And let's take a couple breaths in this position. And what this does is it lengthens our fascia and our pelvic floor so that the breath even does more work, okay? So 2 breaths here. And I'm gonna have you bring one leg into hook lying, or I'm sorry, into our hook lying position, or one leg's gonna come down. We're gonna straighten it out. And we're gonna breathe here, and we should feel a little bit of stretching in the front of the pelvis. Two breaths. And then we're gonna bring that knee back into our chest. Another breath here. And we're gonna straighten out the opposite leg. So the opposite leg's gonna come down, and then we're gonna slide that heel out. Feel the strength there, the stretching in that front hip flexor. Breathing here. And another breath. And then we're gonna bring both knees into the chest again. Okay, so I'm gonna put my left leg down, and I'm gonna put my opposite arm is gonna come onto my right leg. So left leg's gonna come to my right knee, and I'm gonna start to bring my right knee in towards my left shoulder. So across the body, I don't have a ton of range, and a lot of you are not gonna have a ton of range here, and that's okay. So we're just gonna do our best to bring our knee across our body towards our opposite shoulder, and we should feel some stretching through the side of the leg, the back of the hip. You might feel some crunching in the front of that pelvis joint. If you do, you can take a pillow and stick it in the front of your joint, and that sometimes just gives a barrier so that you don't feel that impingement there as much. So we're gonna take 2 breaths here. And from there, I'm gonna bend my opposite knee. I'm gonna remove the pillow, put my right ankle on my left knee, and I'm gonna press my right knee down towards my feet. So I'm gonna get a piriformis stretch here. If some of you are familiar with this stretch, you can reach under your left leg and bring it in towards your chest a little bit more. That's more intense. If that's not your cup of tea, or if that's not what you're familiar with, feel free to just sit here with your ankle on your knee. Okay, and my hand is just resting on my right knee to give it a little bit of pressure out towards my feet. Okay, 2 breaths here. And then last thing we're gonna do on this side is we're gonna keep the ankle on the knee. We're gonna bring the knee towards the shoulder. Feel that stretch down through the back of your hip. And then we're gonna push it out again, okay? And we're gonna repeat that. So in towards the shoulder, out towards the feet. In towards the shoulder, out towards the feet. And you can do that a few times. And then we're gonna remove the ankle from the knee, bring it back to the floor. And we're gonna do it on the opposite side. So we're gonna bring the left leg, I'm using my left leg, across the body to my right shoulder. Couple breaths here. I'm going to bend my knee, my opposite knee, and place my left ankle on my right knee, resting my hand on my knee. I'm going to press it towards my feet. Couple breaths. Again, if you're familiar with this, you can grab under the right leg and pull it closer to your chest. If not, just feel free to rest right here. And if you're feeling that crunching in the pelvis at any time, you can put a pillow in front of your hip joint. So after a couple breaths there, we're going to bring it in towards our opposite shoulder, back towards the feet, in towards the opposite shoulder, back towards the feet. One more time, in towards the opposite shoulder. Feel that stretch in the back of the hip and out towards the feet, where you could feel that kind of back pocket stretch. Okay, so we're going to finish with knees to chest again. And 2 breaths. So just with that little bit of movement,
You might be able to feel that your breath has opened some parts of your body that you haven't said hello to in a while or haven't been able to access in a while. You might feel that the hips are talking to you a little bit, that you're getting a little bit more blood or heat flow through there. And that is all so good for these tissues. Now, staying in whatever position you're in, I'm going to come to sitting so that I can give you just more of my voice, but staying in whatever position you're in, we're going to go into some pelvic floor activation. So let me just pull up I'm on my track here. So imagining that pelvis that we had looked at before, we're going to think of our bony landmarks, the pubic bone in the front, the tailbone in the back, and your 2 sits bones that are right under your, kind of right where the hamstring attaches into your glute. So right between where your bottom and your leg transition, that's where your sits bones are. So we can pair this with breath. And what I'm going to suggest is you pair it with the exhale. So we're going to take a deep breath in, and on the exhale, I'm going to have you draw your pubic bone towards your tailbone. Let's just see what happens there. So pubic bone is coming toward the tailbone. And that's going to be one way to engage our pelvic floor. So after we try that, we're going to take another inhale, and on the exhale, we're going to engage the sits bone. So the sides of our pelvis are going to come in towards each other or in towards midline. So let's inhale, let it all go, let it lengthen. Exhale, we're going to bring the sits bones in towards midline. Okay, after we do that a couple times, sits bones in towards midline. That's just a different way to activate the pelvic floor. Everything is activating at the same time, but it's just a different nuance, again, so that the brain is mapping the whole pelvic floor and we're uncovering any blind spots that it might have. Next, we're going to do, I call it a quadrant circle. So in your mind's eye, and this is a toughie for the brain, so you might feel a little bit of like, ooh, my brain feels sore after doing this. We're going to, in our mind's eye, try to activate the pubic bone to the right sits bone. So upper right quadrant, pubic bone to right sits bone, you're going to try to engage that quadrant. And for me, that looks like pulling my pubic bone towards my right sits bone with my brain. Next is going to be right sits bone towards tailbone. So we're going to pull the right sits bone in towards the tailbone. It's hard. And the posterior ones that we're talking about, so these ones are going to be harder after anal cancer treatment. So I expect that. It's the thought that counts here. The brain just looking at these areas is going to be big. Now we're going to try left sits bone towards tailbone. Okay, now we're going pubic bone towards left sits bone activation. And now we're going to go the opposite way, which sometimes feel really different. So pubic bone towards left sits bone, left sits bone towards tailbone, right sits bone towards tailbone, and pubic bone to right sits bone. So I call that the quadrant circle, and just activating each quadrant of the pelvic floor is so big to your brain to shine the light on all of the tissues that are still there and still able to activate. The last thing that I want to engage is our anal sphincter. So bring your brain to where your anal sphincter is. And I want you to imagine you're closing it. You're closing it and you're lifting it, okay? So we're gonna squeeze it closed and lift it up with our brain, okay? So let's try inhale. And on the exhale, let's close our anal sphincter and lift. And at home, you can try this with different breathing. Sometimes people feel better on the inhale because it feels like you're sucking everything in and it's easier to get a lift. Mechanically, the exhale tends to work better, but we can try both. And it's like we're breathing all the time every day. So we should be able to activate our pelvic floor with either part of our breath. So these exercises it's individual on how many to do a day. And obviously we're not trying to like really strengthen something that's so tight. So for all of you, if you're doing the breath and you're doing some mobility, whether it's what we did today or just some sort of like gentle kind of moving your limbs, I feel safe saying 10 of these exercises a day. So 10 pubic bone to tailbone, 10 sits bones together, 10, of the quadrant circle activations, and 10 engaging just the anal sphincter is totally safe to give your brain the signal like these need to be active, but we're not like overly tightening them. Okay. So it's not one of those things where it's like do 100 a day and that's going to be the thing that cures. We want to activate. And if you can do them in the morning, if possible, that's a great way to start the day. So the brain's kind of, it's waking up, it's coming into gravity and it's getting acclimated to the day. And if we can get that pelvic floor activated as soon as possible into the morning, better. If not, any time is great. So these are the three things that these, breath work, mobility, and some pelvic floor activation can be done by anyone at any time in treatment. You can always improve. The body wants to improve. It's a lot about sending blood flow and, fascial movement to these areas. And so regardless of where you are, I recommend just kind of jumping in and starting. It's a positive thing. And like I said, before, if you can get in with a pelvic PT just to get a personalized plan just for you, awesome. If you can work with someone virtually, that's fine too. If you just go through this and that's all you have, I'm okay with that. The last couple things I was going to say is there's the International Pelvic Pain Society and pelvicrehab.com. I've sent these to Justine and Laura, and they're going to link them in the email that they send after. That's where you can start to look for a pelvic floor practitioner. So thank you so much for listening and for your time. And the next part we're going to go into is to the Q&A.
Thank you, Allison. That was amazing. And I know it was a lot of information for everyone. So we are going to, we've been recording this and we are going to upload it later so that you all have it available to you. We're now going to move into the Q&A portion of the webinar. You are all asking us amazing questions. We only have about 5 minutes or so. So I'm going to try and combine some of the questions that we are receiving so that we can get as much information from Allison as possible. So the first thing that we've been getting a number of questions about is nerve damage. And this is from people who are sometimes even 15 years out. And even saying that it feels like maybe the nerve damage is even getting worse now 15 years out. So if you could speak to what that is from and also what they could do about it now.
Okay, so the nerves do get damaged in this treatment, and it's usually the radiation that does it. I know like some of you are far out past past your initial treatment. So what is happening is because the scar tissue is continuing to sort of like do itself, it's almost like muting the nerves. So the nerves are made of fascia too. And so scar tissue can kind of like grow on them, and it starts to first mute them and then make them feel like there's no point in like responding with you. So actually doing this, like some of the pelvic floor stuff that we just did to get your brain to be very specific to the pelvic floor and pay attention is going to help. It sends something called nerve growth factor out through the nerves, and the nerves literally follow that and grow in response to it. And it's literally like thinking the nerves on. So if we can do some of these activations on a daily basis religiously, then the nerves will start to like wake up a little bit. It doesn't mean they're going to go from like where they're at to a completely new nerve, but they will start to respond in some way. And also giving that tissue some length is going to help with, giving the nerve some room to heal.
Thank you. We've also gotten a number of questions about urinary dysfunction in terms of feeling burning when they pee, how long it should take for urinary dysfunction to heal, and what are some things that they can do specifically to address that.
Okay, so urinary, because the urethra, like I showed you guys, is so close to the anus, and because they share the same nerves, they all know what's going on with each other, and that's why that happens. Burning with peeing is going to be, that's usually fixable by doing some of this lengthening work with the muscles. It's usually not like the urethra is too scarred up. It's usually muscle tightness happening. So breath work is going to be important there. If you can stick a squatty potty or a stool under your feet to pee, that can help like lengthen that canal and make it a little bit more open to allow the pee through. I would look at irritants in your diet too. So caffeine's going to make pee more acidic, carbonation, and alcohol. Those are going to be things that are kind of tough for the bladder to deal with if it's already in an irritated state. Was there anything else about that question I missed, Justine?
No, that was great. Thank you. We have received a number of questions about returning to sexual activity, and in terms of time frame, in terms of pain, in terms of dilators. So in terms of kind of combining all of these questions, first, where can someone get a dilator if they weren't originally recommended to it by their oncologist? And then my understanding is a lot of the exercises you went through today can kind of help with sexual activity. And what is your anticipation in terms of time frame, and how should people kind of expect their progress to go?
Okay, sexual activity is going to be like a work in progress, something that you can continue to work on like throughout the lifetime, like I had kind of mentioned. So get excited to just continue to learn what's working for you and your partner as each road comes through. But yes, some of the stuff that we've done today is helpful, just movement wise, blood wise. But other things about sexual activity is actually orgasms are really good in this situation. So blood flow to the tissue in whatever way that can work for you is super helpful. Dilators can be bought online. My favorite brand is called Soul Source. They don't pay me, but they are my favorite brand because they're not like the hard plastic. They're like a softer silicone. And so sometimes it just feels a little bit less like rigid than the plastic dilator. So Soul Source, and they're sold individually, so they don't come as a set. So you would just start by the smallest one that you think, would work for you, and then you would work your way up. But if you look up vaginal dilators online, and it's always like a vaginal dilator is how they would, be searched, but you can use them in the anus too. That is where I would go, and then there's companies like Good Vibrations, or any, like, you have like a sexual health store in your area, they often sell dilators too. But yeah, orgasms are good. Working with your partner, because it's going to feel new. So every kind of things that worked before are going to feel different, and there's going to be different things that work now. So just kind of re-exploring, getting curious on that. Yeah, it'll be a road to get to your next place of sexual health, but you can get there.
Thank you. Our final question is going to be, could you just walk through pretty quickly what people should look for or ask for when they're interviewing a pelvic floor therapist, and what that first appointment might look like?
I mean, the main thing that I would say, now, not everyone is going to be like so proficient in specifically anal cancer. You could obviously ask them that, and I would. And if they haven't, if they're not familiar with it, I wouldn't leave. I would just take the time to educate them on your experience. But the main thing that I would say, like in these pelvic floor therapists, is there are some people that treat more like incontinence. So you kind of want to say, is that like more your thing, or is pain more your thing, or is it kind of a combo? And depending on what you've got going on, you're going to want to go towards, if someone's like, oh yes, I treat incontinence, that's what I do, and that's what you're dealing with, that would be a perfect match. If someone's like, no, I treat more pain, then we would go, you'd want to try to find someone that's working for you if you're having more pain. If you're having a combo and someone's like, I do this, but I'm willing to work with you, you kind of have to, I would kind of divide it into like pain issues, incontinence issues, and ask them like what they're most comfortable treating. I would say I bias more towards pain issues, but I'm definitely more of like a combo person. And the first appointment is usually going to look like chatting about what's going on. Usually they're going to have you undressed from the waist down so that they can evaluate, the pelvic structures. Usually they're going to look at your breathing, your abdomen, external pelvis, and then internal pelvis. I typically don't check rectally unless I have to in the first appointment, because it's an intense appointment. So if I don't have to check rectally, I will check vaginally in females. But sometimes we have to check rectally that first day if you're comfortable with it, obviously, if you give consent, and that's gives us the information that we need. And then usually you'll leave with a plan of what you can do going forward.
Thank you, Allison, so much. And thank you to everyone for joining us on this Anal Cancer Awareness Day and our webinar on pelvic health recovery after chemoradiation. Thank you, Allison, just for the information and the practical tips that you've given us and sharing your time with us so generously, and your company, Reclaim Physical Therapy. Thank you also to our co-sponsor, the Farrah Fawcett Foundation, for your support. We hope to do more webinars like this in the future, so please let us know what was helpful and what could be improved. I hope you all have an opportunity to do something special for yourself today. On behalf of the Anal Cancer Foundation and the supporters of this webinar, we will be thinking of you and are here to help in any way we can. Have a lovely rest of your day. Thank you.